We're back for part 2 with Professor Tabs talking about pathology, basics of pathology. So let's start by talking about the basic model of pathology, talking about how we get from a normal cell or homeostasis to cell death by either necrosis or apoptosis. So you can imagine we have the normal cell in homeostasis, but then there may be some type of stress, or there could be some injurious stimulus. The stress may lead to an adaptation. We'll talk about adaptation later. But if the adaptation is not possible and there is an inability to adapt, then we would have cell injury. But this is not the end of the story. With cell injury, you can still come back from this. It could be mild or transient, and you could then call it reversible injury, which would lead us back to normal cell homeostasis. But if we have cell injury and we cannot recover from it, then it would be severe or progressive, which would then lead us to irreversible injury. And then there is cell death, and there are two types we're going to talk about: necrosis or apoptosis. So let's talk about these cellular injuries and what are the usual subjects, the usual suspects in cellular injury. Can you think of any? How about hypoxia, infections, immunologic reactions, congenital disorders, chemical injury, physical injury, nutritional imbalance? These are the usual subjects, the usual suspects, I mean. So now let's talk about some of the mechanisms of cell injury. So considering some of the mechanisms of cell injury, let's just discuss some of the principal mechanisms and their biochemical functions. So let's talk about ATP first. What would happen if you had a lowering of ATP? Of course, the cell can survive without ATP. For example, in some cardiac difficulties, it's not the end of the road, but this can lead to multiple downstream effects. What happens when we have mitochondrial damage? Well, this also affects ATP, of course, because this is where ATP is made, but also leads to leakage of pro-apoptotic proteins. How about the entry of calcium? Well, this could increase the mitochondrial permeability and also activate multiple cellular enzymes. How about increase in ROS? Then there would be damage to lipids, proteins, and DNA. How about membrane damage to the plasma membrane or lysosomal membrane? As for the plasma membrane, this would lead to a loss of cellular components, obviously. For the lysosomal membrane, there would be enzymatic digestion of cellular components. And as for protein misfolding or DNA damage, this would lead to the activation of pro-apoptotic proteins, as was said with the mitochondrial damage. Anyway, this is just an overview of some of the mechanisms of cell injury. But just remember that regarding the adaptation to injury, persistent stress or injury leads to cellular adaptation, and this is in the good result. If it doesn't, then it would lead to injury that is irreversible. Now let's discuss adaptation to injury. There are several ways that the cell can adapt to stress. So we'll talk about the trophies and the plasias. So we have atrophy, hypertrophy, hyperplasia, metaplasia, and dysplasia. So what I will do is read the definitions and then you have to guess what we're talking about. Okay, firstly we have a decrease in cell size or cell number and functional ability. This is atrophy. Okay, how about abnormal proliferation of cells characterized by changes in cell shape, size, loss of cellular organization. This is dysplasia. In this adaptation, we have a reversible change of one cell type to another. Remember the three cell types? Well, basically, we have squamous, columnar, and cuboidal. This, of course, is metaplasia. And this doesn't mean that you have cancer, it just is very worrisome to see this change of one cell type to another. Okay, next. An increase in the number of cells in a tissue or organ. That's hyperplasia. Okay, so we've discussed atrophy and hyperplasia, metaplasia, dysplasia. How about an increase in cell size and functional ability due to increased synthesis of intracellular components? So here we're not talking about an increase in the number of cells, we're talking about an increase in the size of the cells. This, of course, is hypertrophy. So what are the causes of atrophy? Can you think of any? How about decreased workload, denervation, decreased blood flow, decreased nutrition, aging or involution, and pressure? So let's start talking about some of those. Now you can't see the pictures in front of me, but I just want you to picture the atrophy of an 82-year-old man's brain in comparison to a young man's brain. And this 82-year-old male has atherosclerotic cerebrovascular disease, which results in a reduced blood supply. So what happens when you have a reduced blood supply? Then there would be a loss of brain substance, which is narrowing the gyri and widening the sulci. Let's consider hypertrophy. Consider an enlarged heart, for example. Is this always good, always bad? Well, it could be good if you're an athlete and you have gained some size in your heart, which is a result of your exercise, but not if it is as a result of hypertension. Of course, then it is a bad thing. But remember that with hypertrophy, it is an increase in the size of the cells and not an increase in the number of the cells. So let's try to think of one example of a physiologic hypertrophy in a female. Well, one often used example is the physiologic hypertrophy of the uterus during pregnancy. Let's talk and think about now the biochemical mechanisms of myocardial hypertrophy. So what are the major known signaling pathways and their functional effects? Basically, there are three. We have the mechanical stretch or the increased workload. We have agonists, for example, alpha adrenergic hormones, angiotensin. And then we have growth factors, for example, IGF-1. So which are the major triggers for physiologic hypertrophy? Would it be mechanical stretching, agonist, or growth factors? Mechanical sensors appear to be the major triggers for physiologic hypertrophy. How about for pathologic states? In this case, it would be agonists and growth factors. These would be more important in the pathologic states. Now let's talk a little bit more about the plasias, explasia anyway. What would you have if you had hypoplasia? Just as a quick review. Of course, this is a reduction in the number of the cells. Normalplasia, normal amount of cells, and hyperplasia, an increase in the number of cells. Let's talk now about metaplasia. Can you think of an example of metaplasia? Remember that the reason that there is a need to switch for metaplasia is to adapt to stress. So an example would be, well, let's just first define it. This is a substitution of one normal cell or tissue type for another. For example, columnar cells for squamous cells in the cervix, or squamous cells for columnar cells, which are glandular, in the stomach, or fibrous for bone tissue. And an often used example here, often seen example, is metaplasia in the case of Barrett's esophagus, where we see the replacement of one cell for another. We would see the replacement of squamous for columnar epithelium. So do you remember what is Barrett's esophagus? Remember that it is defined basically as an esophagus in which any portion of the normal distal squamous epithelial lining has been replaced by metaplastic columnar epithelium, which is clearly visible endoscopically and which is above the gastroesophageal junction. And remember that the most significant complication of this Barrett's esophagus is the development of adenocarcinoma in the esophagus.